evening. Good
Good
evening,
evening.
everyone. Yeah,
Good evening.
I hope that
Good evening.
you are all doing well and had a restful week and a good and productive week. So this week we are having week 3 of our training, the SPARK train, genetic counseling in sickle cell disease. And then we'll have very good and insightful program. And so as much as possible, when we enter the room, we should mute our microphones as we join so that we don't have any feedback. And then at some point, a poll will be launched so that we can be able to fill our attendance. It is a requirement that everybody fill their attendance for the day. So when you see the poll being launched, please make sure you fill your attendance. So for today, we'll have 2 lectures with 2 very seasoned presenters. We have Prof. Prisca and Miss Evelyn who will be presenting to us. The first presentation will be on genetic counseling processes in sickle cell disease, and then we'll have case studies. And then the next will be on genetic counseling, documentation, and referral. We'll listen to both presentations, and then afterwards, we'll have a question and answer session. So what you can do is that as you are listening to the presentation, you can put your questions in the chat box so that we can be able to answer it. And then at the end of it, we'll have some time. If you want to ask your question live, we can be able to do that. And so let me go ahead and then introduce our 2 esteemed presenters. So our first presenter will be Professor Prisca Olabisi Adejumo. So Prof. Prisca is a leading Nigerian nurse, medical sociologist, and academic, currently serving as Dean of the Faculty of Nursing, University of Ibadan. She holds dual master's and PhD degrees in nursing and medical sociology from the University of Ibadan, with advanced training in nursing classification and cancer genetics from the University of Iowa and University of Chicago. Prof. Adejumo's career bridges clinical practice, education, and research, with notable contributions to the genetic counseling of non-communicable diseases, including sickle cell disease, stroke, and cancer. She has been pivotal in integrating genetic counseling services into healthcare systems across Nigeria and Cameroon. Her global impact includes a consultancy for WHO on COVID-19 preparedness across 8 African nations and co-leadership of the NIH-FIC D43 SPARK Train project. She was inducted into the Sigma Theta Tau International Nurse Researcher Hall of Fame in 2022. She's also the founder of the Focusing on Young Nurse Initiative, fostering early career nurse development through mentorship and training with over 120 peer-reviewed publications. Prof. Adejumo continues to shape interprofessional healthcare education and practice across Africa and beyond. And so there is no other person, no right person to do our presentation for us than her, and she'll do justice to the topic that is given her. The next presenter will be Miss Evelyn Acheamp. Ms. Acheamp obtained a diploma in nursing as well as a BSc in nursing from the University of Ghana. And then she holds an MSc, a Master's in Family and Child Psychology from the University of Chester, United Kingdom, and a Chevening Scholar. She has specialized in hematology nursing from the Ghana College of Nurses and Midwives and is currently a hematology nurse specialist at the Child Health Directorate of the Komfanochi Teaching Hospital. She's a certified sickle cell genetic counselor and the nurse in charge of the pediatric sickle cell unit at Komfanochi Teaching Hospital. She has been involved in the care of sickle cell patients for the past 15 years and trained several healthcare professionals in the management of sickle cell disease. And so we'll have the honor of having her also do the second presentation for us. And so I will unshare now and then invite Prof. Prisca at Adejumo to start with giving us the presentation on genetic counseling process in sickle cell disease with case studies. And so welcome, Prof. Prisca Adejumo. Thank you.
Thank you very much. Please let me know if you can see the slide that I'm trying to share. Are you able to see the slide, please?
So from my end, there's not yet, it says started screen. Okay, it's now, yeah, I can see it. Prof. Prisca, I can't hear you. Or is it from my end?
Please, Dr. Vivian, can
somebody else confirm?
I can see your screen.
Yeah, so I can see it from my end.
Yeah.
I see your screen, Prof.
Okay. Thank you very much for your very kind words. I appreciate your kind introduction. Yes. Dr. Vivian,
No, I think Prof. Prisca.
Can you hear me? Can you hear me?
Yes, I can hear you now, but your slides are off.
Okay. Okay, I'm using two devices. So if you can hear me, yes.
I can hear you.
Okay, now I switched over to another one. Thank you very much for your kind introduction. The title of the presentation for tonight from me is Genetic Counseling Process. And last week we did general overview, so we'll be dovetailing more into sickle cell disease tonight. And the first slide that I have there, the title slide, followed by the table of contents, we show to us a few things we'll be looking at. Introduction.
Excuse me, Prof. Prisca, your slides,
yes.
It's gone off.
Recording in progress.
Okay, that means I have to reshare again.
Yes, please. Yes, please.
Can you see it now?
I am not seeing it. I don't know whether, yes.
No, we can't see it. Okay.
Yes, so we can see
Okay, I can
it now.
see now.
Yeah.
Can you hear me?
Yes, we can hear you now, and we see your
Yes,
slides
ma.
also.
Okay, so we are the first one is title slide, which shows genetic counseling process in sickle cell disease, and the next slide is talking about genetic counseling process in sickle cell disease, and the next slide is talking about table of contents. I'm having delay, so I can hear a delay in what I'm saying. Please, can somebody confirm?
Yes.
Yes, there is a delay. I think you have two devices. So if
okay,
you
let me turn off the second device.
Yes, I think it will be. And then please put it on slideshow for us. Thank you.
Please, somebody should be admitting because I'm going to leave admitting people now. So just be admitting all.
I'm admitting them as they enter, as they are entering. I'm admitting them.
Okay. Okay, so can you see the slideshow now?
Yes, we can see the slideshow now. Yeah.
Yes, ma'am.
Can you see the slideshow?
Yes.
Yes,
we can.
yes, Prof, we can.
Yes, ma, we can see.
So I think we can kick off right now. A lot of time. Right? So, table of content, and we are moving on to a kind of introduction. Yes, thank you. Okay, so what genetic counseling is all about. And I'm taking this from Emery Arimoy's Principles and Practice of Medical Genetics and Genomics 2019. It says genetic counseling is a process. It is not something that it undergoes series of processes. So that process has a very important assignment. And that assignment is to give information and give actual risk or the potential risk move from parent to offspring or from one gender there. It includes information and so on and so forth. The aims of genetic counseling in sickle cell disease, I have about 3 of them. The first one is that whatsoever it is that is going on at any given point in time or a point given time, you want to identify families at possible risk of sickle cell. And then you need to gather information. We did all of this with Dr. Acheamp, Professor Alex Osaikoto, Professor, and so almost all the speakers have touched on this. So I'm sure we are all experts in knowing how to identify whether there's going to be 25%, 50%, 25% of which one, whether it's carrier status, whether it's actual sickle cell, and all of those things. And then apart from helping in that identification of possible risk of sickle cell, it also helps to gather and analyze patterns. So it will be very obvious, and based on that, the counselor or the healthcare professional will be able to provide information about need for genetic testing and other procedures that may be necessary. So if you take a look at this, the second point, you will see the first generation, second generation, and the third generation. So this could stand for maybe the grandparents, and this could stand for parents, and it could stand for children. So if you look at this man and this, the third point is going to take us to. All of these lines and this to be clearer. Where the direction, in line 2, there's a filling up of this cycle and a filling up of this square. So which is the presence of hemoglobin SS. And when there is none, then it's hemoglobin A, and there is no filling, it's empty circle or empty square. Then all of this will assist with decision making, either by individuals or by parents or by couples or whoever that need detailed information and explanation regarding the information that has been gathered from the family history and the patterns that have been seen from the pedigree that has been developed. And then one can provide accurate information to either the individual or the family. Don't forget our focus is genetic counseling tonight. Both this first presentation and the second presentation, we'll be looking at genetic counseling as a whole. And so the process, I have about 5 different steps that are described here in this process. The first process, the first phase or step is assessment. And I always tell people, if you cannot assess, you don't have business providing care or counseling or giving information or managing anyone, whoever you are, especially if you are a nurse. So assessment is very important. If you do not clock your patient as a physician, for example,
Then you don't know which of the differentials you want to settle for. Which diagnosis are you going to come up with? Because you have not assessed the patient. As a nurse, you may not be able to come up with the nursing diagnosis that you are going to do business with if you have not assessed your patient. So assessment is vital. And there may be need for screening and diagnosis in step 2. And step 3, you need to analyze. And based on your assessments, the screening and the analysis you have done, you can now communicate and provide information to your clients, to your family, and then the decision can be taken, whether decision to make referral or decision to go for a test or decision to go for other procedures or whatever decision will be communicated. And that person you are dealing with will be able to make an informed decision. And then we can go to the last phase or the last step of the process, which is that you don't provide information and leave the person. You actually go ahead to support and then make referral where need be. So let's start from the first step or first phase, assessment. It's called the beginning phase, like I said earlier on. It's the phase where you are coming in contact with the clients for the first time and you're interacting with the person, whether the individual, whether a child, a young person, a man, a woman, parents, relatives, or whoever they are. Then information gathering takes place at this time. You are doing your assessments, but you need as much information as you can have. So it's a phase, beginning phase, interacting initially, and then you are gathering your information so that the information, the predictions you are going to make can be accurate. And in addition to information that you can get primarily from the clients, the family, the members, whoever, you can also get information from medical records, either for the patient that you are facing or the family members, to be able to clarify or verify what you have obtained during session. I've shadowed sessions where the patient will be able to will be saying, no, that's not what I'm saying. And I have counseled patients where, in an attempt to rephrase what they have said for me to be sure, they will say, no, that's not what I meant. And they will explain. So it's a very important foundational phase in genetic counseling process. And then, as a counselor, the information to be collected should be detailed enough, whether it is family history or medical history, so that different kind of illnesses captured. If there is any opportunity or any occurrence of miscarriage or miscarriages, stillbirths, or deaths that cannot be explained in the family, all of those must be captured in that detailed family and medical history. Then you should be able to discuss what they know about sickle cell disease. And based on their level of knowledge, you match them up where they are and provide current and correct detailed information about sickle cell disease to them. Then, depending on whether the person you are dealing with is an individual, as a woman of reproductive age, or is a couple, then you deal with the concerns and the goals that are related to sickle cell disease, because they will differ. If you are dealing with a school-age child, or you are dealing with a university student, or you are dealing with a marriageable single, or you are dealing with two people who are about to get married, or you are dealing with already married couple who are planning pregnancy, or you are dealing with a couple who have come with pregnancy. So the goal of interaction with them will be dependent on the kind of person that you are also interacting with. Then you can begin to draw your pedigree. All of these interpretations is based on the analysis, and that will be reflected on your pedigree. So to construct your pedigree is a family tree diagram. a diagram that shows family relationships, which make use of various symbols to represent people and lines to represent relationships. So genetic relationships and people are diagrammatically brought together to illustrate what is going on with the people you are dealing with. And those diagrams, the illustrations of the various arrows or lines rather, makes it easier for you to be able to visualize what type of relationships exist within the families, particularly if you are dealing with extended families. When I was in a country where drawing the pedigree was so simple and straightforward, when we come for hands-on, we will take a lot more time to talk about this. And the pedigree is always very simple: a father, a mother. Then the line will go down, and then we join the two together to show there's interaction between them and their offspring. And we show the offspring 1, 2, 3, and then it ends. Then when I returned to Nigeria, and I had to start drawing pedigree of a man who has 9 wives, and the 9 wives have 4 children, 7 children, 8, 2, 1. And it became so complicated, very interesting. I believe that one day, as we begin to interact with people with different conditions, especially sickle cell disease, it becomes clearer to us that it can be simple and straightforward, but sometimes it can become complex. But what is important about this family tree is that it makes it easier to visualize the relationship that is going on within the family. And generally speaking, squares represent males, while circles represent female. Somebody jokingly said that men are disorganized. They have different angles. So they are represented with squares, while women are neat, fine, neat, close, neat, neat people like that. Wherever they are going, they are facing. That is just on a lighter mode. But it's very simple to remember. Circles are females. The wedding rings that women wear in places where they wear their circles. And you can tell me that men don't wear square ring. Excellent. But the point is, anything that will help you to remember, just adopt that females are represented by circles, while males are represented by squares. And this is a medical symbol that shows different types of symbols. Offspring of a family is progeny. A proband is the first family member, whoever you are coming in contact with as sickle cell disease patient or person, or whoever has that issue that you are dealing with at that point in time that you are counseling or you're interacting with. That is the proband. It's also possible to have consultant. Consultants are individuals that are seeking genetic counseling. They don't necessarily have any genetic disorder. They may just be concerned. They may just be worried about something, and they are clarifying it. So they are consulting. So they are called consultant. Well, the first family member who has been identified as having the genetic disorder, sickle cell disease in this case, is a proband. So that's a difference is there between a proband and a consultant. But as the diagram and the symbols are showing, like I've said, when you see a square, it means it's a male, a circle is a female. So the sex of these people is known. So you know this is female, you know this is male. If by adventure you cannot say it's a male, so you don't know whether it's a square, and you cannot say it's a female, so you cannot say it's a circle, then use the diagonal shaped object to represent that individual with unknown sex. So once you see that rhombus or that diagonal shape, it means that you do not understand. Yes, you cannot hear me. Hello, somebody is saying, Prof, can you hear me, please?
Yes, we can hear you.
I hear you, ma.
Okay, thank you.
Hear you, ma.
Where the sex is not known, you use that symbol. And when the person is a non-sickle cell disease person, then you fill the box, you fill the symbol. The symbol in these three are empty. They are not filled. It's just talking about sex, male and female and no sex. But in this one, it is filled. That means this person is affected. When it is completely filled, when it is halfway filled, like this, then it is a carrier or a carrier or a carrier. The spelling is different from carrier, which is double ER. But someone who is carrying a trait. So that's what you do. You fill it halfway. If it is completely, specifically an X-linked recessive one that you are sure of, then you just put a point like you have here. And if it is dead, whether it's an adult or a male or a female, then you cross it out. That means this life has expired. So you cross it. In this case, is stillborn. In this case, a female, and in this case, a male. But you cross outside of the symbol, which means it's dead. Now, the horizontal line shows mating. This is a mating line. It means that this man is married to this woman, and this woman is in a mating kind of relationship with this man. They are two different individuals from two different bloodlines. But if they are blood relatives, and these blood relatives are in a mating relationship, then the line becomes two. One to show it is a mating relationship, and the other one to show they are blood related. So it's a consanguineous mating, like in the Jewish Ashkenazi. Then you have sibship. The sibship is a line that shows that this is a brother and a sister. So they are both joined together, but above, not horizontally as in a mating relationship. You see, the mating relationship is horizontal from center to center. This is above, joining both together. Then you have dizygotic twins, which shows that two of them are two different, not identical twins. And so you have them as entity, individual entity, and you have a line that shows that both of them are joined together and they are from one mating relationship that gave birth to them. Monozygotic twins means that the same thing happened, but both of them are identical twins. So these are the symbols. There are several symbols, uncountable symbols, but generally speaking, once you have all of these ones, you are almost good, because for many, they will be derivable or derivative of these ones that are here. So when you are constructing your pedigree, it is very important to understand that the horizontal lines, like I've said, there's nothing here that is new. The horizontal line is connecting a male and a female, like the last slide showed, which represents a mating relationship, while a line that is extending downward from a couple is showing the progenies, the children. And the subsequent generations are going underneath the parental generations, while the older or the oldest individuals are found at the top of the pedigree. Those are the parents and the grandparents and the great-grandparents, like that, like that. And if any individual is affected, then the symbol is shaded. First degree relatives, FDR, is an abbreviation that is very common. It's referring to children, brothers, sisters, and parents, direct siblings. It's coming from the same parents. They are first degree relatives. The second degree relatives are uncles, aunties, grandparents, nieces, half siblings, and so on. They have relationship, but it's not first degree. That is second degree. And of course, we have third degree, where you have first cousins, great aunts, great uncles, great grandparents, and so on and so forth. A diagonal line through a symbol indicates that the person is diseased, like I've said. And you have Roman numeral 1, Roman numeral 2, and Roman numeral 3 showing different generations. So Roman numeral 1 is talking about a generation, 2 another generation, and 3 another generation. So these are children, these are their parents, and these are the grandparents. So each Roman numeral figure is talking about a generation. But if you observe, you will see that apart from the Roman numeral, this 1, 2, 3, you also have a conventional 1, 2, 3, the Arabic numerals, 1, 2, 3, 4, like that. Those ones are representing the birth order, the order of siblings. So this person is older than this person, older than this person, older than this person, and like that, up to the last child. The same thing here. This is first child, second child, third child, fourth child, fifth child, sixth child, like that, and like that. So if there's information that you see that an arrow cancels out or crosses across the symbol, then it means that that individual is diseased. And then you don't just leave a diseased person alone. You don't allow that person to rest in peace. You want to probe. Because by the time you are gathering the information, based on the information you have gathered, you need to assess the risk of inheriting or passing on sickle cell disease. So you need to explain the inheritance pattern of sickle cell disease, whether it's autosomal, like we have been told, that both parents will need to carry the gene for a child to be affected. You have to explain the difference between sickle cell disease, sickle cell traits, all that Dr. Acheamp and the other presenters have taken us through. As a person that is drawing the pedigree, assessing the client, obtaining the information, analyzing the information that has been gathered, it is your responsibility to be able to explain the inheritance pattern. Because like I said, the pedigree drawing is to make it easy to visualize patterns. And so all of this need to be communicated to the individual. If you are dealing with sickle cell disease, you explain what it is. If you are dealing with sickle cell traits, you explain the implication. So that will end the first phase of assessment. And the second phase of the process is screening and diagnosis. And the goal is to make decisions on genetic disorder. You want to be saying there's sickle cell disease here. So if there's need for confirmatory tests, chromosomal analysis, biochemical tests, we're told of HPL, test last week, or yes, last week, as it differs from the general solubility test. And we're told the importance of confirmatory tests so that somebody will not just come and say, oh, they say I am this today, tomorrow I am another one, so that you are able to confirm. I have series of that. Even currently, after the class last week, somebody still called. And somebody asked a question in the class last week. Okay, the test was this, and now it is this. What type of test did you do? And we'll come to that later on. So all the various tests that I've done, Dr. Acheamp took us through them. I won't waste our time again on electrophoresis, HPLC, the solubility tests, and so on and so forth that we went through last week. So don't let me belabor it. We did all of this last week, and it's just a way of reminding us that when a blood sample is taken, to be able to identify the specific mutations in the hemoglobin gene, you can do Sanger sequencing, can do application refractory mutation system using PCR. You can do deletion and duplication analysis. And in all of those things, your analysis will be in consultation either with an expert or in combination with literature. What is literature saying? And in conjunction with the pedigree that has been drawn, which is derived from the family history that has been obtained. So none should be done without all of these conglomerates being put together. If you're not a native doctor, you should not look at somebody and say, oh, this person has sickle cell disease. Yes, I know that you will say, but there are certain features, that you see, yes, but please, let's actual test be done, and if possible, confirmatory test be done to be able to make a diagnosis, which is very important. So the meaning of autosomal recessive inheritance pattern was explained last week. So I don't know whether I should still talk about it again. That it is autosomal because, and it is recessive because you need 2 copies to be able to manifest. And if you have a dad and a mom who are both carriers, this is what you are likely going to have. Unaffected child is going to be 25% chance. A carrier child, 50% chance. And a child with sickle cell disease, 25% chance. Now, what is important to lay emphasis on here? I think it has also been emphasized that it is in every pregnancy. It's not that, oh, okay, maybe when I have 1 child, then that's okay. So it has settled, then I can continue. No. In every pregnancy, that is the chance. So somebody can have a chance. I know I've heard that, okay, after, it's not real, no, it's a myth, so that nobody goes away with that. That after a certain number of children, then the whatever is going on stops, and then you can start having normal children. And some people, they now have 9 children, 12 children. No, it is not correct. We should give correct and correct information. Even if you have 100 children, the chances and the possibility and the risk is there, and you should understand it, that in this particular case, 25% chance of having an unaffected child, 50% of having a child that is a carrier, and 25% chance of having a child with sickle cell disease in every pregnancy. Very important. So we need to be able to understand the risks and the inheritance in sickle cell disease. And that's what I've just explained. Autosomal inheritance. Please mute your device. Please mute your device. Thank you. Okay. So carrier status, individuals who carry 1 copy of the sickle cell disease are called carriers, or people who have the traits. Generally speaking, they look healthy, they appear healthy, but they can pass
Prof, you are muted, ma. You are muted, ma.
Somebody must have unmuted everyone. Or somebody must have muted everyone. Can you hear me now?
Yes, ma.
Okay.
Yes, we can hear.
Okay, thank you. So, understanding the autosomal recessive inheritance nature of sickle cell disease is important. Understanding the carrier status is also important. And then the risk assessment is vital. The types of.
Hello, Prof. Prisca. Please, can you mute the other device? There's an echo. Prof. Prisca, we can't hear you.
But I can hear you loud and clear.
Okay, yeah, I can now hear you.
Okay. Has the echo gone?
Yes,
Yes,
it's now
ma.
gone.
Okay, thank you. So there are different types of tests. The diagnostic one, if a person is symptomatic and you want to confirm to say, oh, I don't have hemoglobin SS, then you go and do a test for that kind of diagnosis. Or if it's carrier testing, this individual is a carrier. So you want to know, and a genetic test needs to be done to detect the gene mutation, or a prenatal testing. If an individual is pregnant and wants to know, can do a test during pregnancy, you know. And then you have pre-implantation genetics diagnosis, where the testing is done in the presence of mutation to select the unaffected embryos to be implanted. It carries some risks, but it's doable and it's possible. The genetic screening. The target is not high-risk individual or family, but you just offer the test systematically to general population or a specific group, like newborn screening, like Professor Nodu took us through last week. So there are different types of tests that are done in genetic in sickle cell disease. But what is important is you don't just leave the test. So there are some key areas of genetic counseling in sickle cell disease, like before pregnancy, couples need to be counseled about the risk of passing on to their progenies sickle cell disease. That is before pregnancy. During pregnancy, information should also be provided. If there's going to be prenatal testing, for example, and the support that should go along with it. The same thing with post-diagnosis. Even when diagnosis has been made, there's need for support. And if the people are literate, resources can be provided to them, whether it is actual sickle cell disease or sickle cell traits. And for newborn screening, family need to be helped to understand the implications of a newborn screening results as much as possible. And we also spent time in, I think it's Professor Alex Osekoto who took us through estimating the risk of sickle cell disease using mode of inheritance, family history, pedigree analysis, and the tests that are done. And also took us through Mendel's law. All of them are very simple. What is important, you can easily infer by looking at the pedigree, some level of risk can be assessed. And if Mendel's law is used, it can also be used to make that estimation. For example, if you have a couple, man and woman, and they are known to be heterozygous carriers of autosomal recessive condition because they have a child with the disorder or because of a testing that has been done. So the probability is 1 in 4 with each pregnancy that the child will inherit 2 mutant alleles and then actually inherit disease. That's table that I showed earlier on that showed 25%, 25%, and 50%. That 25% chance that the child, yes, will be a complete free child from sickle cell disease. Another 25% of actually coming down with sickle cell disease, and 50% chance of being a carrier. So that kind of estimation can be done with that. It can also use Bayesian analysis, where Punnett calculators are used, and it just simulates inheritance patterns and add population data. It's like using risk calculator. The accuracy of this is a little bit, how do I say, not 100% accurate. But if you have pedigrees that are correct and appropriately drawn, and you want to use it for education, then this can be done. You can also use proper family history. Normally, we know that if you are considering clinical and demographic risk factors, age is a simple, straightforward matter. Mortality is highest in children under 5 years old. That's why people feel like once you can survive, the older you are, the higher your chances of survival. It's a general belief, because even children that do not have sickle cell disease, you know that mortality is highest and under the age of 5. And so if that is now compounded with sickle cell disease, of course, it now becomes highest mortality. So age is a factor. And then newborn screening. Routine newborn screening, very crucial for early diagnosis and intervention. Very, very crucial. Like we were told last week by Professor Unodu. So we are looking at this scenario. We are supposed to break into sessions where we'll be looking at this type of scenario. The scenario 1, you have both parents with sickle cell traits. And each child has 25% chance of inheriting 2 normal genes. And so if you have that means that you do not have sickle cell disease. Fantastic. So you have normal one, then you have 50% chance of inheriting 1 normal and 1 sickle cell gene. So that is the sickle cell traits, or what you call carrier. And then 25% chance of inheriting 2 sickle cell genes, which is sickle cell disease. In the risk scenario 2, there's one of the parents has sickle cell disease and the other has sickle cell traits. As you can see in this scenario, what is going to happen is that each of the children will have 50% chance of inheriting 1 normal and 1 sickle cell trait. And there will be 50% chance of inheriting 2 sickle cell genes and actually coming down with sickle cell disease. The risk scenario 3, 1 parent has sickle cell disease and the other parent does not have sickle cell disease. I believe we did this with Dr. Acheamp already. And each child will inherit the sickle cell gene from the parent with sickle cell disease, resulting in sickle cell traits. That is this one. And the scenario 4, you have both parents normal in quotes without sickle cell disease. No sickle cell disease, no traits. Then all the children, we have no risk of sickle cell disease or sickle cell traits. So this is straightforward analysis that can be done and will be very easy to do interpretation and very easy to give counsel to parents. Now with risk scenario 5, 1 parent has sickle cell traits and 1 parent has thalassemia traits. So each child in this scenario, which is a little bit different from the other ones we have seen so far, each child will inherit the sickle cell gene from the parent with sickle cell disease, and that will result in sickle cell trait as well. So the parents are here, and the offspring with sickle traits and sickle beta thalassemia is here. So the normal gene is what is represented as red, and the sickle gene is represented as green. So beta thalassemia is represented as purple. So these are the offsprings. And this is sickle cell traits. This is sickle beta thalassemia, and this is beta thalassemia. So these are the various analyses that must be made interpreted and passed on. Number 4 is communication and decision. We have 5 first, I will soon be done. So communication and decision is important. Counselor explain all of these interpretations, the analysis to the clients and whoever family members that need to be informed, the details of the test that has been done, making sure that they understand what it means and the consequence or the implications and the clarification of the meaning. And for carriers, the risk of passing on the gene, even though they live a healthy life, there's no problem at all, but the impact it will have on future pregnancies and ensuring that they do not get married to a person who is also, a carrier, and getting that information to those children of theirs who will be carriers is very, very important. This is where the issue of communication is. And with communication comes decision making. Very important and critical. Some people will ask you, should we pursue carrier testing? Okay, can we reduce the current risk for future children? Do we even want genetic testing or we don't want? If we want, where can we do it? How much does it cost and so on and so forth? I think we ask a lot of questions regarding that on the day we have the presenter who took us through all of this. So counselors, you provide emotional support, social support, and all manners of support. And if possible, refer them to support groups where individuals can be supported and be helped to cope with implications of this. So you could have prenatal diagnosis, family planning, post-diagnosis support, whatever type of diagnosis you have is the determinant of the type of decision that the clients will need to make, which is also directly related or proportional to the type of support that will be given. If there are options, for example, for prenatal diagnosis, like amniocentesis or CVS, it can be explained. And family planning, to assist individuals and families to make informed decisions about family planning. You can't say, oh, I don't want family planning. It's very important for them to understand why family planning is of necessity, and reproductive options as well as their potential risks should be explained to them. And then after all of this, support, social support, emotional support to families who are dealing with this diagnosis, and even management of a person with sickle cell disease is very important. And finally is referral and support. We must refer the individual to specialists for further interventions like prenatal diagnosis or other treatment modalities. And they provide psychological support. Like I said last week, genetic counseling is one discipline that brings the beauty of interprofessionalism. So this person may need psychologists, experts to be able to, cope well and adapt well. Don't let us take it for granted. It's very important to be able to help that individual. And communicating in a very effective way is important. Use clear language. Though this is not the time for jargons. So if you have complex issues, please clarify them. If there are concerns, address them. If there's need to refer to higher level of authority or experts, do so. But make sure that individuals and families are not advised, but they are given opportunity to make informed decisions about their reproductive options, about their healthcare options, about whatsoever. And I think I've made example of 4 case scenarios. In closing, I think I have 2 or 3 or 4 scenarios. This is a 27-year-old man with hemoglobin AS and a 25-year-old woman also with hemoglobin AS. They want to get married. They are not aware of the potential genetic risk to their future children. So can you go to the chat room in the next 5 minutes that we have and put for me in the chat room what do you think should be done? In this case scenario, a couple, they are planning to get married and there's a career status conflict. The man is 27-year-old with hemoglobin AS sickle cell trait, and the wife is a 25-year-old woman, also with hemoglobin AS. They are ready to get married. They are planning. They are not aware of any, but both of them are healthy. And so what is the problem for any future children? So please go to the chat room and put your thoughts and your comments and your reflections there. As you are putting those things there, you have to think about autosomal recessive inheritance we talk about. You should be able to guide them concerning 25% risk of having a child with sickle cell disease, SS genotype, with each pregnancy. Very important, with each pregnancy. You should be able to discuss reproductive options with them. Pre-implantation genetic disorder with IVF, prenatal testing, adoption, use of donor garments, and so many other things. And you can provide non-directive counseling to them to assist them to make informed decisions based on their own faith, not your own faith, based on their values, understanding, and preferences, not on yours. And then you offer referral to fertility specialists if they consider carrying out pre-implantation genetic diagnosis. And then encourage prenatal screening as a public health tool. Because of time, I'm going on to scenario 2. This is a pregnant woman with sickle cell disease. Her partner is with unknown status. The pregnant woman is 28-year-old and is confirmed sickle cell disease with SS genotype. She presents for antenatal care, but her partner has never been tested. Does anybody want to talk to her? Anybody want to explain to us what we should be, the focus and the goal of genetic counseling in this case? Please, can you help me to check if any hand is up? Is there any hand up? Okay, no hand is up.
I don't see any hand up.
Okay. So what will be happening with this?
Okay, there's one hand up now.
Okay. The person should go ahead.
So you can
Please
unmute and
unmute
speak.
the person. Let's hear.
Hello.
Hello, go ahead. Thank you very much.
Hello.
Hello, Prince.
Yeah,
We
so
can hear you.
with regards, sure. So with regards to that, I think the benefit is to call in the partner and then explain the chances of passing on the sickle cell trait to the offspring. So we'll screen the husband to find out if he is a carrier of the trait or he also has the SS condition. Carry it on with a prenatal diagnosis.
Okay, thank you. Excellent. I have 3 other hands raised. Who are they? Can they speak? Dr. Vivian, 2 other people who have raised hands. Can they talk?
Yes, please go ahead and speak. Please, those who have raised their hands, you can go ahead and speak, please. They're unable to mute, but I think we have.
Okay.
Aaron, can you help us to unmute them?
Don't worry. Let me just go ahead. You urge
Okay,
partner.
so
Okay, go ahead.
Yeah.
all right, so Adebayo can speak.
Good evening, everyone. Good evening, Ma.
Good evening. Go ahead. Am I the one that cannot hear anyone or is not speaking?
I think he's not speaking because I
Okay.
also
You
can't
unmute.
hear.
Okay.
He has not
Okay, no
unmuted.
problem. Let me just say the genetic counseling goals are, the first speaker already said it. You urge partner testing to determine the career or affected status. Very important. That first speaker said it. And then you explain that if the partner is AS, the child has a 50% chance of being a carrier too, and 50% chance of having sickle cell disease. And you should offer prenatal diagnostic options for them to find out the genotype of the fetus. You should give them opportunity and encourage them to participate and engage in partners' career status by doing hemoglobin electrophoresis if you have it in your facility. If you don't have it, you refer them to where it is available. And if both peradventure are SS and AS, then let them know the potential clinical cause for the child. And then coordinate prenatal diagnosis when the baby is born and perinatal care, and then support them emotionally and medically throughout their pregnancy journey. It is very, very important. You will see that everything that we are talking about, emotional support is topical, is pivotal, is important. In all of them, you want to make sure that as much as possible, you are not leaving the person, you are not just giving information and running away. You are there to assist and to guide and to support. So thank you very much, all those people who spoke and those who could not unmute, apologies. For the case 3 is a newborn diagnosed with sickle cell disease and they are first-time parents. 3-month-old baby is diagnosed with sickle cell disease via a newborn screening that was done, and the parents are shocked because they are unaware that both of them are carriers. So genetic counseling goal is to help both parents understand how sickle cell disease is inherited. So it's not somebody that is guilty, it's combination of both. So you have to explain to them, provide emotional support to process guilt or blame. You can refer them to psychologists to guide them through that and discuss the long-term management plan for the child, offer career testing to extended family members like siblings and so on and so forth, and deliver the diagnosis compassionately, avoiding technical jargons, and provide a clear treatment roadmap for them, including prophylaxis, immunizations, hydrotherapy, all the things that are useful and needed for the child. Very, very important. Hydroxyurea, everything that is available should guide and help. Introduce local support groups or sickle cell disease foundations and encourage cascade trainings and screening for relatives. Case 4, and I think that's the last one, is with sickle cell disease. Is a woman with sickle cell disease considering pregnancy scenario. So a 30-year-old woman with sickle cell disease who wants to become pregnant but is concerned about health risks and genetic implications. So the goal of the counseling of the counselor is to discuss medical risks of pregnancy in women with sickle cell disease like preeclampsia, infections, vaso-occlusive crisis, and they prepare the person. So you can advise on preconception evaluation by a hematologist, obstetrician, so they'll be able to say that, okay, as you are in a good condition, generally speaking, everything is taken care of for you to go ahead or take care of this, take care of that in preparation. Then explain the importance of partner testing to assess genetic risk to the baby. That's another kettle of fish, apart from the 30-year-old woman herself. They recommend comprehensive pre-pregnancy assessments and high-risk obstetric care. They refer the partner for hemoglobinopathy screening and counsel on fetal genotype possibilities based on partner status and support mental and emotional preparedness for parenting with sickle cell disease. Yes, a teen discovered she has sickle cell trait. 17-year-old girl, she learns she has hemoglobin AS during just ordinary routine school screening. She has no symptom, but she's anxious about what does that mean for her future? Will she get married? Blah, blah, blah. So you need to reassure her that most individuals who have AS or who are carriers or who are trait carriers, they live normal, healthy lives. However, you should educate her about potential health risks during, for example, extreme dehydration or intense physical activity, and then importance of partner screening when planning a family. So age-appropriate education should be given to her, and all her questions should be answered correctly and openly as possible, and share guidance on safe physical activity, hydration, and future reproductive implications without causing or inducing any fear. Then encourage keeping documentation of her status for future reference. So this is the summary table of all that we have said about scenarios. I think about 5 scenarios of career, couple planning, marriage, pregnant woman with sickle cell disease, newborn diagnosed with sickle cell disease, then a woman with sickle cell disease planning to become pregnant, and a teen with AS. I'm giving us this assignment. We have to take it home. And then when we get to our various sessions where we are going to have hands on, for those of us who we have hands on, then we can present it. And for those of us who will not have it, we have to draw the pedigree of a family, of a couple. Prenatal diagnosis for sickle cell disease can be offered through amniocentesis or chorionic villus sampling. Genetic counseling is crucial to explain the procedures, risks, and benefits, and to help the couple understand the implications of the diagnosis. So in a case study, a couple chose to decline PND due to concerns about miscarriage, despite having 2 cousins with sickle cell disease, highlighting the importance of respecting individual choices and values. Draw the pedigree of this couple and discuss their concerns with the interpretation of the pedigree. So I believe the assignment is clear. In summary, all I've been able to discuss in the last 1 hour is about genetic counseling for sickle cell disease, having capability of empowering individuals and families to understand their genetic risks and making informed decisions about screening, diagnosis, and treatment options. Thank you very much, and you are greatly appreciated for your patience and attention. Over.
Thank you very much, Prof. Prisca, for such a wonderful presentation. I believe that we have all learned a lot. We'll have our second presentation before we will go to the Q&A sessions. So, Prof. Prisca, can you please unshare for us so that we can share Evelyn's presentation? Thank you. Okay, Evelyn, Miss Evelyn, please, are you on the call?
Yes, please.
Okay, so I'm sharing your screen for my end. Okay, so Evelyn will present on documentation and referral in genetic counseling for sickle cell disease. So I'll hand over to you. If you want me to move to the next slide, you can tell me. I will do that. Thank you, and over to you.
Good evening, everyone, and thanks for having me. I'm going to present on documentation and referral in genetic counseling for sickle cell disease. Next slide, please. So by way of outline, we have definition of documentation, components of documentation, importance, and then challenges in documentation. So what is documentation? So documentation is a planned and accurate recording of all important clinical, psychological, and educational information gathered during the counseling process. So in the course of genetic counseling, every information obtained is accurately documented. And this serves as an official record of the counseling section for communication and continuity of care among healthcare providers, and also aids in legal and ethical accountability. Components of documentation. So we are going to discuss what forms documentation. So when you are documenting in counseling, we start with the patient information, and this includes the name, date of birth, sex, medical record number, ethnic background, and this is important for risk assessment, family history of hemoglobinopathies, and then the current diagnosis, whether patient is hemoglobin SC, and S beta thalassemia. Also, we document referral information. So what the source of referral, whether the referral is coming from primary care, hematologist, ONG specialist, and so on, we document. And then the reason for referral. Then we move on to the family history, we document it. Third generation pedigree, like great grandparents and the rest, we document. And then if there is consanguinity, like bloodline relation, we also document that. And neonatal deaths and or miscarriages that cannot be explained, we document. And then ancestry, we realize that those from African or Mediterranean, they are prone to sickle cell disease. They have a greater risk of sickle cell disease, so we document that as well. And then if any genetic testing result is available, we document that as well. Next slide. Additionally, we document medical and psychosocial history. So the personal history of sickle cell disease symptoms, like painful episodes, transfusion, hospitalization, then psychosocial concerns. How is the client coping? Support system, mental health status, reproductive history and plans, especially in women or couples. Then how the client understand or perceive the condition, we document that as well. Next slide, please. We also document risk assessment. For instance, if the career status of the individual is known, we document it. And the risk to children with probabilities, like we know that if we have two AS couples, they have a 50% chance of giving birth to a career child. We document that as well. Then recurrence risk for future pregnancies, we document all that. Additionally, any education during the counseling process, any education or counseling given, we document. Basically on the inheritance pattern of sickle cell disease, how we describe the sickle cell disease, like AS, career trait, and the rest. We everything that goes on during the counseling session, the basic genetics, clinical features, and variations of sickle cell, then the career testing and genetic testing options, everything we document. Newborn screening, importance of partner testing, reproductive options, we document all those things, information. Then during the counseling session, patient questions and consents, we put them in writing as well. And any misconception addressed, we document. Whether there are cultural and religious consideration, we document all those things as well. Decisions and follow-up plan. How patients understand sickle cell, we put those information down. And after counseling, if there are any referrals made, for instance, to the hematologist or obstetrician or psychologist or IVF specialist, we document. If there are follow-up plans, like testing for partner and prenatal counseling, we document all this information. And after counseling, if any resources or materials were given out, we document that as well. Consent and confidentiality are two key important things. Before counseling, we consent, we ask for consent. So we document informed consent during the counseling. And then disclosure of results to partner or family if applicable. We document all those things. And we respect for privacy of the client and the family and the autonomy as well. So all this information, we document them as well. And lastly, after the counseling session, you as a counselor, you put down your name, your signature, and your professional designation, whether you are a hematologist, whether you are a genetic counselor, whether you are a nurse, a doctor, and so on. And the date of the session, you document it. So what are some of the benefits of documentation? So in documenting, we ensure accuracy and consistency in care. This means that whatever that we document, it serves as a reference for continuity of care. And it's aids in patient autonomy and informed decision making. And the documentation also helps in legal, when there is any legal and ethical record, it serves as a legal and ethical record. Then it enhances team communication and future care planning. So some of the pitfalls in documentation or challenges. Incomplete or inaccurate family history. So some clients may not be able to provide information regarding extended family issue like the pedigrees and the rest. Or some may not be able to know the status of their relatives, and this may be a challenge in documentation. And low health literacy. Some of our terms that we use in counseling, like phenotype, genetics, genotype, some may find it very difficult to understand, and as a result, it may be as a challenge in documentation. And stigma and cultural beliefs. So in that society, because of stigma, that's like if you have sickle cell disease, you are labeled or you are tagged. A lot of people do not want to disclose information about their status, and that may hinder documentation. And we know that some of our clinics are quite heavy. When that happens, time constraints may also hinder documentation. And last, language and communication barriers. We know that we speak different languages, and during counseling, you have to come down to um, the level of the patient or the client. So in doing that, we cannot, some of our times we are not able to use the appropriate terms for it, and all these things may hinder communication. And then emotional distress. You know that during counseling session, some of the sessions can be quite emotional. And as a result, when this happens, information may be hindered, or the patient may find it difficult in releasing information, and that will hinder documentation. And technological barriers. For instance, when we have paper-based records, it can easily be missing. And some of our hospitals too do not have the electronic health system, or the electronic health system too is uh, inadequate or not available in some of our hospitals, and this may become a challenge in documentation. So we move on to referral. So what is referral in sickle cell genetic counseling? So by way of outline, we have definition, purpose of referral, who needs referral, when to refer, sources of referral, benefits and then challenges in referral. So referral means you direct an individual or couple to a genetic counselor or somebody who is specialized in sickle cell genetic counseling for assessment, education and support concerning the inheritance, diagnosis and management, as well as the reproductive implications of sickle cell disease. So you identify someone as an expert, and then you identify sickle cell patient, and then you refer the person to the specialist for further consultation. And the purpose is to identify individual carriers or those at risk of passing the disease to their children. And you provide prenatal or before birth. You provide prenatal or preconception counseling to couples who are at risk, like couples who are both AS or carriers. Then it helps in diagnosing sickle cell disease or related hemoglobinopathies. Then it offer psychosocial support, and it helps family understand the implications and make informed decisions. For example, if you have two couples who are AS, you provide them with psychosocial support so that by the end of the counseling, they'll be able to make informed decision. And you refer for further testing. Next slide, please. Who should be referred? Who? So we refer individuals who know that who have been tested to have sickle cell disease, whether it is hemoglobin, SS, SC, S beta thalassemia, for understanding of the inheritance of the disease, so that they will be able to plan their family as well. So carriers of sickle cell traits, both carriers who are AS, especially when both partners are carriers, right, or do not know their status. So couples planning a pregnancy or currently pregnant, if either partner is a known carrier or has a family history of sickle cell disease, we refer them to the specialist. Next slide. Parents of newborns with positive newborn screening. So when you give birth to a child and the child has been screened from the newborn screening and it's positive, you refer the patient. And individuals with family history, we've already said that, of hemoglobinopathies, whether SC or SS, and at risk ethnic group, as we've already mentioned. Next slide, please. So when do we refer? We refer before pregnancy, and this is suitable for couples who are known carriers, that's both are AS. Then prenatal period. So once a pregnancy is confirmed and you identify the risk, you refer the patient. And then at diagnosis, following a diagnosis in a child or adult, or before bone marrow transplant, to understand the genetic compatibility and risk. Next slide, please. Sources of referral. So we often receive referral from primary care providers. So they refer patients who are confirmed sickle cell disease and they need specialist care. So primary health providers include those at the we have family physicians and the rest. Then we also have hematologists. They refer patients for genetic counseling. Then during antenatal clinics, during screening, during pregnancy, pregnant women undergo a lot of tests. So when they identified as being carriers, we refer them. Then pediatric clinics after newborn screening. Then schools or communities. Routinely, we have programs for community screening and the rest. So during those screening, when anyone is identified as having sickle cell disease, we refer them. Next slide, please. So referral specialist. When the person is identified as having sickle cell, they are referred to see genetic counselors. So the genetic counselors, they give genetic information to the patients, so about their risk and their options. hematologists, they also manage the medical aspects or parts of the sickle cell disease, including the treatment and complications. And then we also have gene experts or geneticists. They also provide expertise on genetic testing and interpretation of results. So what are the advantages of referrals? So referrals ensures that genetic testing and counseling, it helps in identification of genetic changes or mutations. And then patients and families receive information about their risk and options so that it enables them to take informed decisions. So referrals to specialist care ensures complete or holistic medical and emotional support. So when we refer a patient to a specialist, everything about his or her condition like sickle cell is explained, and then they are supported emotionally, and it helps in family planning. So if you identify yourself as a carrier, you know the risk of passing the disease to your offspring. Challenges of referral. So there are limited access to specialist service. We know that in our parts of the country, we have limited specialists like hematologists, the genetic counselors. So that serves as a big challenge. And also there is poor communication between providers. In a hospital, you can refer a patient from a smaller hospital to a bigger hospital, but the one from the receiving end will not receive any information, and then it's because of poor communication and patient related problems. You can refer somebody to a bigger facility, but due to financial constraint, they will not be able to go to the specialist facility. And then also there are delays in the referral process. And then social cultural factors, some due to stigma and the rest, they are not able to access specialist care. And then technological limitations. So in conclusion, documentation and referral are two major parts in sickle cell genetic counseling. Accurate documentation provides quality care, ensures quality care and accountability, while timely referral facilitates prevention, early intervention, and informed choices for individuals and family at risk. Thank you. Your questions are welcome.
Thank you very much, Miss Evelyn, for that wonderful presentation. I think that I will stop sharing so that, okay. So we'll start with the Q&A session. Okay. So I have a few questions that were in the chat box. It's the first one was that for the Prof. Prisca, for the symbols for the pedigree, it looks as if the stillborn and the dead are the same. Can you please explain that? That was one of the questions in the chat box. Hello, Prof. Prisca. Please, are you there? Aaron, can you help? I think that she's muted. I don't know whether she's not able to mute. Unmute.
Hello, can you hear me?
Yes, we
Hello?
can hear you. Hello, yes, Professor, we can hear you now.
Hello, can you hear me?
Yes, you can be heard now.
Okay, thank you. Yes.
Yeah.
Okay. So, for the symbols, they are straightforward diagrams, and if you take note of very popular ones, they are the same wherever you find them. For example, just know that for a man is square. So anywhere you see square is a man. In your mind, interpret it to be a man, a male, a boy, or whatever. Then if you see square, a circle is a woman.
Prof, okay, I think she's even off. Okay, so there's another question here which says that
have you heard the first question? That you are moving to the next question.
Yes, I think you dropped off at some point.
Okay, I was talking away. I didn't know you didn't hear me.
No, we didn't
please,
hear you.
Permit me to quickly finish it. For the person who asked the question, those three things are important. Now, those lines, those symbols, when they are crossed across, that means it's like it's cancelled out. That means that person is no longer in existence. That person has died. So you use that, you cross the symbol when you are talking about a dead person. And when you see that symbol in sickle cell disease or any genetic disorder you are handling, it becomes important because you want to probe what caused that death. If it is related with sickle cell disease, that is where your probing starts from. So it's very important. And another important thing is whether the symbol is filled fully or is filled partially or is filled on point. And then finally, is the lines, whether the line is mating line or ship line. If it is straightforward from a male to a female or other direction, it shows that this is a mating relationship. And once that is horizontal. If that horizontal is true, it's a mating relationship, but that mating is in a blood relationship. But if it's heterogeneous, it's just two individuals, then it's just one line. But when it is vertical, not horizontal, then it shows that these are the descendants from that mating relationship. Those who emanated from that relationship are the ones that are descending down below that. And of course, if they are joined together above, not at the center, not consanguinely by double strike horizontal, then they are siblings. So you can Google symbols for pedigree drawing. There are so many resources for it. It can be done electronically. There are softwares, apps that we if you just fill in the history, the 27-year-old man is a non-sickle cell disease person. It will just be putting the symbol and drawing the thing for you. At the end of the day, you just have your pedigree drawn. But here is paper and pencil. We use paper and pencil. We ask questions, we put it down, and we use hand to manually to draw the symbols to represent what we are talking about. So thank you. That's all about that. So you said the next question is, I didn't get the question.
Yes, so there is another one on the pedigree, which says that if you can throw more light on the dizygotic and then the monozygotic.
Okay. I'm sure that, especially for those of us who are in Nigeria, if you come to Ibadan, rather, when you come to her, if you are lucky to be selected for the hands-on, we will spend more time on this. And I'm glad Dr. Anyango is in, and then she will take a lot of time to explain all of this to the participants more. So what happens is two individuals, twins, if they are dizygotic, they are not identical. So there will be no line joining them apart from the line that indicating that they are sibling. There will be no other line. But if they are identical twin, there will be another line apart from the line that shows that they are brothers or brother and sister or sister and sister. There will be another line again that shows that, yes, this is a twin, but they are identical twin. Because of nature-nurture controversy, environment where they grow up, and so many things that is happening that may affect individuals, and the fact that they are identical and so on and so forth. So it also has consequence in interpretation of the pedigree and in analyzing the pedigree diagram. So the two of them, the only thing that differentiates them is this additional line that is for identical twins. Otherwise, it's the same symbol. You just have a symbol that is horizontal, showing that both of them are descending or offspring or emanating from a mating relationship above them. And then because they are twins, it's not just going to be one line as in all other normal children. It will be two, going to the two of them. But if it is that they are identical, then there'll be additional line that join the two together. That's all. Over.
Okay, thank you. Thank you very much. There was another question on what test can one conduct to distinguish SCD sufferer from a patient suffering from thalassemia? And how do we distinguish the two? Prof. Prisca, do you want to take that? So what I want to say is that we normally don't say SCD sufferer. Okay, most of the time we say people living with sickle cell disease because it's sort of stigmatizing if you say SCD sufferer and things like that. So let's make sure that we say the right terminologies and call them in the right way. Okay, so Prof. Prisca, do you want to answer that?
Okay, let me add a little bit to it, and then we can allow Ms. Acheamp to also contribute to it. From where you stopped, the fact that they are living with, we don't even want to say they are living with, because if people have malaria, you don't say there are people living with malaria, or they have diabetes. You know, it's also how do I put it now? Derogatory. Okay, there are people with not living with this, living with that. So it further corroborates this the explanation you gave earlier on is stigmatizing, and you don't want to do that at all. Now, concerning the test that you are going to do, I think Dr. Acheamp took us through a lot of tests for thalassemia. I think Professor Aseikoto that took us through the various electrophoresis that you do, hemoglobin electrophoresis, which is confirmatory. And then I don't know who took, I think it was the same person who said that if you want to be sure of what you got, maybe, okay, oh, this one is looking like F. Okay, I think it's Dr. Acheamp, because she showed us one tablet that says that, okay, if you are looking at this, it shows A, it shows S, it shows AC, He showed this, he shows that, all of those things. And she said, if you want to do a confirmatory test, you should actually do a high performance liquid chromatography. Now, if you are talking about thalassemia, to the best of my understanding, for me, I think, and I don't know if any other person that is in can actually contribute, to this. If you are trying to say you are doing DNA analysis, that's when you'll be talking about, okay, it is this particular gene, maybe it is deleted, or you are using Sanger sequencing to find out which exact sequence of DNA bases in a gene is missing, or is deleted, or is added, or is duplicated, and all of that. But when it comes to thalassemias, it is only those who are experts in that field that will be able to say, this is B thalassemia, this is this peculiar type of thalassemia or not. But I think when Dr. Acheamp took us to, she explained different kinds of tests that could be done. So I would suggest that once you are thinking that, oh, this individual is not hemoglobin A, is not hemoglobin F, is not hemoglobin S, is not hemoglobin A and C, is not hemoglobin E or F or G that are not very common, then it is important you ensure that that person actually see an expert. So don't make up anything. Please, I plead with you. If you don't have understanding of what a simple solubility test can give to you, or a rapid test can do, or a normal confirmatory test that goes beyond the usual solubility testing or electrophoresis, and you want to be doing high performance liquid chromatography or HPLC, please, let's make sure that you have an expert involved. That's simple counsel that I will give. Let's Ms. Acheamp contribute to it, or any other person in the house who is a laboratory expert can also help us to add to that.
Okay, thank you, Prof. So just let me add on a few things. So for those with S thalassemia, mostly you can use HPLC to help distinguish it, because for those with S thalassemia, mostly the level of the hemoglobin A2 will be increased, mostly more than 3.5%. And so if you see that, it gives you an indication that that patient might also be suffering from S beta thalassemia. Okay, and so the best is for you to refer. If you are suspecting that a patient has a thalassemia, it is always best to refer to a specialist who can do all the other tests that are needed, so that you can come to a great conclusion and a final conclusion for that. Okay, thank you. And yeah.
Madam Acheamp, do you want to add, or any other person in the house, or even the person who has the question, do you want to add anything to it? Okay, you can go ahead to the next question.
Yes, so the next question is that I have a family whose 3 children are AC, but one of them usually presents with generalized bone and body pain. Please, what is the explanation?
You see, the last question, if you take note of the last question, I said, please always make sure you see an expert. Don't do proxy questions. Nobody can tell you the reason why this individual has vaso-occlusive crisis, if that's what I heard you asking. Generally speaking, if people have the straightforward genotyping that has been described, you don't have a problem until when an exacerbation occurs, like in pregnancy, like maybe they find themselves in very high altitude where there's compromise with hydration. Generally speaking, it is not known. I have seen people that do not even know that they have any strain of sickle cell disease. They don't have any idea until they are adults. And you start wondering, why is that so? Somebody asked last week that a woman, I've forgotten the question, but for those of us who were in, she said a woman was told the genotype was AA, and then later they now said it is now SS in pregnancy and the first time. So if you see AC genotype or hemoglobin C trait, what is cardinal is that this person inherits one normal hemoglobin A and one hemoglobin C. And most of the time, all the ones I have seen, there are no major health problems associated with the AC genotype. In fact, I've heard that, it offers some protection against malaria. And if you might counsel for anyone, once there is anything that is different from AA, Biko, marry someone with an AA genotype to avoid any trait, whether it's C, whether it's A, whether it's AC. The way and the essence of all of this capacity building is to make sure that we decrease, if possible, bring to zero level as much as possible. Because an individual that has AC genotype, he possesses both the normal hemoglobin A and the hemoglobin C variant. Even though it doesn't cause sickle cell disease, and generally speaking, like I've said, it's the person lives a normal, healthy life and can live to normal life expectancy. But the offspring of that person should not go and marry either AC, SC, SS, AS, whatever. That person should be counseled to go for AA. Marrying somebody with either AC or AS or AS or SS can bring about an increase in the chances of their children having sickle cell anemia or sickle cell trait or whatever. And if you have two people who have AC, and if they marry, their children could then inherit the different combinations, including sickle cell disease itself. So the best thing for me for counseling for couple with or individual with AC genotype is to seek genetic counseling. If you think you cannot offer or you don't have what it takes, refer them to a genetic counselor. So before they start thinking of having children, getting married, all of those things, as much as possible, it is very, very important that they seek guidance and they seek expert opinions and genetic counseling proper, not even opinions, before they take any step. That would be my counsel.
Okay, Miss Evelyn, there's a question for you. Please, how many at-risk races are implicated in sickle cell disease?
Please come again.
How many at-risk races are implicated in SCD? I think in one of your slides, you mentioned something like that. So one person is asking, who are the at-risk races that you were talking about?
Is it traces or races?
Race, R-A-C-E.
Okay, how many at-risk races?
Yeah. I think in your presentation, you mentioned something about African, those who are African, those who are Mediterranean,
Caribbean.
Middle East, yeah, Indians and all that.
Yes.
Yeah, and so those might be some of the at-risk people. But currently, because of movement, almost everybody is at risk because people are intermarrying. But we know that Africans, we have a very high chance of having SCD because of the high rate or career rates that we have. Okay.
You know, there's a lot that is going on with epidemiology of sickle cell disease. And the general philosophy of increased risk being linked to regions where malaria parasite was common. I think it was Professor Alex Oseikoto who explained, all of those, someone having a sickle cell disease, having a protection against malaria and specific variations in different places that you even have some in Ibadan that are Ibadan, Benin Republic, and all of this. But we all know that as Africans, it's high. Not just talking about South Asian, Indian countries or Spanish-speaking heritage, or all of those Mediterranean that you talk about, like Greece and Turkey. and all of those people, groups who are at higher risk. But we in Nigeria and Ghana, honestly speaking, it's a very serious matter, especially in newborn. I don't know whether it looks like all efforts that have been put into it is not yielding enough results. And it is the reason for which this is giving it attention. We in Africa, especially, I've met many people with sickle cell disease in Canada, in the US. Honestly speaking, you will not see the typical phenotypic appearance. I don't know. So, for us, all of us in this class, as Africans, as Ghanaians, as Nigerians, what is my role? What am I going to do? Because it affects us more seriously, and we need to do something about it. What are we going to do? How are we going to leave the Mediterranean, the Middle East, the South Asian, Southern America ancestry alone? But all those races, yes. But for us, we have a very high vulnerability because people don't listen to information, because people have magical religious explanation of diseases and illnesses, because people believe that, what, I'm a Christian, so don't misunderstand me. Somebody who knows that he is AS, another person is AS, will say that, don't worry, everything will be all right by the grace of God. Yes, everything will be all right by the grace of God, because God is God. But he is also sovereign, and he chooses what he wants to do. He will not by yourself knowing fully or knowingly going into something, and then you will now be saying that, okay, he did not do what he's supposed to do. It's because you yourself did not do what you're supposed to do. So that is the essence of all of this that we are talking about. So for me, more interest is in us as Africans, on much more than all the other races, where the number of races that are at risk. But African as at risk, as a vulnerable, as a high incident, high prevalent environment. What can we do, and what should we do, and what should we be doing? Thank you, Madam Evelyn, and thank you, Dr. Vivian.
Okay, thank you very much. So the attendance poll has been submitted. So please make sure that you sign attendance for today. Everybody should sign the attendance. We'll go to the next question. Please, what can a counselor do to help if couples with the SCD traits cannot afford an IVF for the selection of the normal hemoglobin genotype, or they should stop giving birth since they can't afford? So Prof. Prisca and Evelyn, please, anyone can take it.
What a tricky question. Madam Evelyn, what do you think? They're already married. There's nothing we can do about it. So we can support them as much as possible. But if they cannot afford amniocentesis by slowing adoption, they want to have their own children. They don't want adoption. I think if there are other prenatal screening methods, and then they should see experts, obs and gynae. They should see obstetric and gynecologist experts who can provide other prenatal screening methods that we help them process and then maybe make any difficult decision about their pregnancy path if they don't want to talk about amniocentesis or they can't afford it. And maybe they can look at help. They may need to relocate. There may be opportunity to relocate from wherever they are. But the question you'll be asking me, that people that don't have money to do invasive prenatal screening, you are now talking about a relocation. There are so many ways, and they can do blood samples that is not amniocentesis. There are other non-invasive prenatal screening tests but my counsel for me is see an expert obs and gynae professional, so that the couple can be assisted with resources We can look for advocacy groups. There are advocacy groups, non-profit organizations that have financial aid for medical procedures in such situations. If it is sickle cell disease, because people believe that sickle cell disease is not what individual brought upon themselves. The individuals are not aware. The individual by themselves did not do anything. They don't have a hand in it. They just found themselves like that. So there are people who are ready to help and assist in such if it's such circumstances, they're ready to help. They even help with not just advocacy, not just funding, with location, so that they are giving all necessary support. But if all of these fail, then I always like couples to express their feelings, fears, anxieties, so that you know how to help them cope with the emotional burden. If they provide alternatives that they have, then you can help them to navigate. Yes, they don't have money for amniocentesis, yes. What are the other options that are available if they go and see a gynecologist and a gyne obstetrics and gyne expert, and they lay all the options before them? Which one do they feel that they may be interested in following according to their concerns, their beliefs, their value system and everything? And when they have made their choice that aligns with their personal and all the limitation of funding and everything has been taken away from, then we can support them, give them all the support with what it is. Time to feel happy by themselves that yes, this is what we want. So that is what I will say. Madam Evelyn, what do you think?
Prof, I think we
Vivian,
can
too,
refer them to a specialist, like the
okay.
IVF specialist, and they will advise them.
Okay.
Yeah. And just to add on, it's not only IVF, there are other processes that can be done that are not so expensive like the IVF, and all those can be explored. But as much as possible, we need to involve the right people, which are the specialists who can help, so that they can help them make the right decision for it.
Absolutely.
Yeah, I think we have about 3 minutes, so we'll just take one last question and then we will end it here. So someone has asked, which screening test is or are more specific for newborn below the age of 6 months when screening for SCD, since there is presence of hemoglobin F within that time frame? So I think this Eunice did it last week. And just to add on, it's most of the time isoelectric focusing is done. But currently with a point of care test, some of the point of care tests, you can also use some of the point of care tests, which can help you. I know that in Nigeria, you are using, people use that the hemotype SC, and then people are also using the Gazelle. Yes, also for it. And then all those, that is the early infant screening are also done. So below the 6 months, all those are things that can be done. But traditionally, it's the isoelectric focus in the IEF that was being done. But currently with new point of care tests, that is also being done for them. Okay. And there is a very controversial question here. I think government need to make some laws that will prohibit incompatible couples from getting married, because many people, because of their religious belief, go against this teaching, and it is a violation of those children's rights to live. What about that? So Prof. Prisca and Evelyn.
What about the rights of the people themselves? If you are thinking about the government, there's no government that has a right to say that law. Again, if you are sickle cell, if you marry, you should not have a child or anything. You know that there are some churches now, I don't know about mosque, but I know there are some churches that says you should go and do tests before you get married. And some of the tests they are doing, including to find out whether an individual has sickle cell disease. And if not, then they will not marry you. There's no singular global law against sickle cell disease anywhere. And the reason, and those people who are promulgating laws and all of those also know that it will be against anyone to say it will be wrong ethically and legally to say you must not marry if you have sickle cell disease. Then what are you going to do for them? But there are policies and initiatives that are, though not written, but are against. They are tending towards what the questioner is saying. Those initiatives are stylishly preventing or controlling or doing some kind of interference by asking them to do all those tests and things. And once they know that, oh, it's sickle cell disease, then what about people with sickle cell disease discriminating against them in a place of work? It's even written that you should give them opportunity. But when people know, they say, well, for like the day today, you'll be sick, tomorrow you'll be going to clinic. They will not. What is government doing about that one? So if government cannot do anything about that one, why you now want to let them say, okay, promulgate law that they should not get married? Then there will be double jeopardy. Somebody cannot get married, cannot get emotional support, and the person cannot get a job because rather they should look for dedicated clinics. They should give aids for people if they have sickle cell disease. They should make hydroxyurea free for people with sickle cell disease. So if you are having laws that are addressing sickle cell disease, I don't know this Anambra State. There's one Anambra State sickle cell disease control and eradication law that they want to provide publicly funded treatments. And if you see the criticisms that came against that thing, that what do they mean? Why would they do that for sickle cell disease? The only sickle cell disease that is condition that people have in Nigeria. Why are they looking after sickle cell disease alone? So there should be a national bill or a bill to establish national sickle center, national comprehensive care for people with sickle cell disease, and so on and so forth. But not to say that they should not get married or they should be prevented from having children. No. That would be against their own rights. That's my thought.
Thank you very much. Ms. Evelyn, do you want to add anything to that?
Personally, I think from the junior high schools or the primary schools, much education should be held at those places so that the people who understand right from the young age, they will be able to understand sickle cell disease and know their status, so that going forward or when they are aging, they'll be able to make informed choices on their own when they grow up. And much understanding will lead to like them. If you are AS, you prefer to marry somebody who is AA. If they understand it, they'll be able to make their own informed choices. So it's not an order that if you are AS, you should marry somebody who is A. It's their own choice, it's their own decision. Our own is to provide each and everyone with much information, so that based on the information that they have, they will be able to make their own informed choices. That's my little distance on it.
Okay, thank you very much. And so as health professionals, we need to be able to counsel our clients or our patients adequately so that they can be able to make the right and then informed decisions, and they can be able to make the informed decisions that they need to. And that is what will help them. All these laws might not be helpful, but making the informed choice is the best for us now. Thank you, Prof. Prisca. Thank you, Ms. Evelyn, for those two stimulating presentations that you give us. And then I think I really love the Q&A sessions and all the questions that were brought up. And thank you for all the participants for being so very interactive. We'll continue tomorrow at 6 a.m. Ghana time and then 7 a.m. Nigerian time. And we'll be expecting to see you all. The attendance poll has been launched again for those who haven't yet done it. So get it done immediately because we expect everyone to have attendance filled. And so we'll be checking on that. So those who haven't yet filled it, please do it right now. And thank you all for making it. We'll meet again tomorrow morning, same time. God be with you all. Bye-bye. Prof. Prisca, should we meet before?
I don't know whether people want us to still meet tonight or not. Because we've tackled everything. And you are the one that is still
Yes.
moderating tomorrow.
Yes.
So I think